Friends, we now come to the final part of the CME, the treatment aspect of hypercalcemia. Calcium levels less than 12 milligrams and more than 10.3 milligrams are mild hypercalcemia. No appreciable clinical benefit will be there for the patient. Of course, they need evaluation as to why there is hypercalcemia, is there a remediable cause, and should it require immediate treatment. But any patient with serum calcium more than 12 milligrams % should be aggressively treated to prevent hypercalcemic crisis. Calcium levels of more than 40 milligrams is associated with hypercalcemic crisis and is an emergency, and the patient should be admitted and should be immediately treated to reduce the calcium levels to at least safer levels of 12 or 12.5, so that the patient will not go into the cell membrane electropotential problems and cardiac arrhythmias and conduction problems and other things. Always remember to correct the serum calcium value for the serum albumin, as we have already discussed in the initial parts of the presentation. Now, what are the 4 treatment modalities that are available for treating a case of hypercalcemia? As you can see here, the 4 different approaches of treatment. The first and foremost, of course, is the hydration using intravenous saline and vigorous diuresis to throw the calcium out from the body by renal excretion. Remember that this forms the basic and very important step of hypercalcemia treatment of whatever may be the origin. And then, of course, use of glucocorticoids, particularly in cases where the hypercalcemia is due to vitamin D intoxication. And of course, to control the severe hypercalcemia, we have the bisphosphonates and we have the calcitonin to be used in combination to control hypercalcemia. We will be able to discuss a little more detailed way each of these modalities in the coming slides. As far as the treatment of hydration and diuresis is concerned, vigorous intravenous saline diuresis using normal saline. When we say vigorous, means the urine output should be around 200 ml per hour. 200 ml per hour means 5 liters of urine output. Remember, normal urine output is 1.5, and in this particular patient we are going to achieve 3 times the urine output. That means there must be at least fluid input of 5 liters or more per day. That is 10 to 12 bottles of normal saline or even more of normal saline to correct the rehydration first, so that the urine output is maintained at least 200 ml per hour for the next 1 to 2 days. While giving such an extensive, vigorous normal saline diuresis, one danger could be overload with sodium, particularly in patients who are having congestive failure, particularly in patients who are waterlogged, cirrhotics, nephrotic syndrome, people who have renal dysfunction. Using such a heavy load of saline could be a problem. So we have to be guarded in using saline diuresis in patients who have no contraindications for saline diuresis. This is absolutely safe, and kidney can easily handle the sodium load when the kidney is normal, and then we can achieve hypercalcemia to be reduced at a much faster rate using IV saline diuresis. But if sodium input of such a great quantity is not desirable in a particular patient, we can try to maintain the urine volume at least 100 ml per hour. That's around 2.5 ml of urine, 2.5 liters of urine per day, so that around 5 to 6 bottles of sodium chloride normal saline is infused. And once the patient is rehydrated, then we have to give the patient furosemide, which is the loop diuretic, which we commonly use for diuresis. This furosemide is given in a dose of lower doses here, not like in congestive heart failure 4 ampules, 5 ampules of Lasix. We will be using here 10 milligrams to 20 milligrams of furosemide, or any other loop diuretic for that matter. Torsemide also can be used, but remember to hydrate the patient first before we give diuretics. The safest and most effective treatment of hypercalcemic crisis is saline rehydration. First, saline rehydration See that the urine volume is at least 200 ml or 100 ml per hour or 5 liters per day, and then followed by furosemide. Of course, in people who are postmenopausal women, there is beneficial effect shown by estrogen replacement therapy and some of the new RCTs, but these take quite a while for the calcium levels to come down. So this is not the first thing that we try to do. Vigorous saline diuresis followed by furosemide loop diuretic to excrete the extra calcium that is there in the body. Whenever the sodium is washed out, along with that calcium also will be thrown out of the body, and hypercalcemia will be corrected. Of course, once the high level of calcium from 14 milligrams or 15 milligrams has been brought down to reasonable levels of 12.5 or 13, we can continue with the saline diuresis forever. So we have to institute measures to see that the calcium levels are controlled by using this approach, a combined approach of calcitonin plus bisphosphonates. Calcitonin, as we know, is a hormone from the C cells of the thyroid gland. It is its mechanism of action is it promotes the excretion of calcium and phosphate through the renal tubules. In severe hypercalcemia refractory to saline diuresis, calcitonin can be given. It is available as Jicalvit or miacalcin. It's available as 100 ml, 100 international units per ml in 1 ampule. So we may have to use 4 ampules every 6 hours, or 6 to 8 units per kilogram body weight, not exceeding 8 units per kilogram body weight, either intramuscular or subcutaneous. 1 ml ampule, each 1 ml ampule contains 100 international units. So 4 ampules at a time, given intramuscular or subcutaneous, every 6 hours for 2 or 3 days. The reason here is, initially when we give calcitonin, it has got a very rapid onset of action, but the duration of action is very short. That is the reason we have to give every 6 hours. The problem with calcitonin is patients develop tolerance to calcitonin, and the calcium lowering effect will vanish after 48 hours. So there is no point in continuing calcitonin after 2 days or 3 days, by which time the bisphosphonates that we start along with calcitonin will take over. Bisphosphonates take at least 48 hours to 72 hours for them to act and reduce the calcium levels. During that period, the calcitonin given in this fashion will take care of the hypercalcemia and bring down the hypercalcemia. By the time the bisphosphonates act, the calcitonin effect will start vanishing, and then the tolerance start developing. Then we will discontinue calcitonin. We will see the dose of bisphosphonates in the subsequent slide. As you can see here, there are several bisphosphonates available: zoledronic acid, tamindronate,